All right, you guys, welcome to the I Believe podcast. I am here with Dr. Basil Williams from Bascom Palmer Institute in Florida, and we're super happy to have him here with us. You guys have heard him speak before. He's actually, I guess I didn't tell you this, so I'll put you on the spot. We're going to compliment you live on Facebook. But we've had a lot of patients come in and just say that they really appreciated the way that you talk and how you explain things. So we're glad to have you explain more and out of the sun as much as you can because it is hot, at least where I am. It's hot. But real quick, by way of announcements, if you haven't seen this yet, it is going to go up on social media later today. We do have an Eye on Research little mini seminar coming up, just like a teaser of research presentations and just talking to the different researchers, scientists, doctors who went to ASCO, AACR, ARVO, the various different cancer conferences where uveal melanoma has been discussed at thankfully a higher percentage of these talks and these presentations than previously. So if you want to learn more about the present research and kind of where does uveal melanoma stand in terms of metastatic, in terms of research for the eye, make sure to register with us. You can actually go to tinyurl.com/I as in the eyeball. So I on research number 23. And so if you type that in, you'll be able to research or register today. And then if you see the post on Facebook, make sure to share it with your friends and get registered. It is free. And we are just going to be doing just a short 2 to 2.5 hours just to cover what has been presented on in research. Next up is this next few weekends and really this next few months. We have some various 5Ks that are happening. So if you have not joined a Looking for a Cure team, please do so. Please make a team, even if you are just doing one virtually, and help us fundraise for an area, a walk in your area for uveal melanoma research. Keep in mind, if you don't know this already, that in each of the local areas that we're going, for example, Palo Alto and Seattle are coming up. Seattle is tomorrow, so register today if you want to go to Seattle. But each of the areas are raising funds for their local area as well as uveal melanoma research just generally. So half the funds will go directly to the local area where the walk is being hosted. For example, Fred Hutch Institute and Dr. Stacy in Seattle tomorrow. So we've got to have the fundraising efforts happening on your part and your family's part. Just join in, be part of the fun, and just be part of the movement to make a huge imprint in the field of uveal melanoma this year. So we have Palo Alto coming up next weekend. Dr. Murthy and Jaya is hosting with Bayer's Eye Institute. And then coming up in August, we've got Philadelphia and New York City. Philadelphia, we had to move the date. So just keep that in mind that we are doing that again in the middle or the beginning of August is Philadelphia and New York City. And then I believe in September is Denver, Colorado. Also in September, I know we have lots of things. Also in September is our I Believe seminar, and that is happening on September 8th and 9th if you're joining us virtually. And if you're joining us in person, we hope that you will fly in for the 7th, which is going to be our welcome reception. We're going to have just a good time in the evening to chat, get to know each other, and then the next few days of just chock full of resources that you can use as a new patient, as a seasoned patient, or as a caregiver if you are one of those people. So thank you again for joining us. And now I'm going to move on to our discussion for today, which is actually brought to you specifically by Castle Biosciences, who's one of our sponsors of the podcast. And they put forth Dr. Basil Williams as the best person to explain prognostic testing for us again, and just to really kind of dive into some of the questions you guys have as a community. So, Dr. Williams, thank you so much for being here on your Friday evening, and we're so glad to have you.
Thanks so much for the introduction and for your kind words earlier. I'm obviously blushing. And then in regards to participation, I don't know if I'm the best person to talk about it. There's a number of wonderful ocular oncologists, but I'm happy to participate and to join you.
Well, thank you so much. So, we've got, just kind of some various misconceptions that float around in the community, even now, like as we have newer patients who are being diagnosed. So, we want to just let's just talk about maybe some of the common fears that patients might have, or that doctors, treating doctors might even have around doing a biopsy. And so, I guess maybe we start back with what is a biopsy as far as treating the eye, and what is the purpose for you as a doctor in doing that biopsy?
Yeah, sure. So I think that's a great question, and that's obviously a great starting point. So when we think of a biopsy, usually it's a needle-based biopsy, and so we're getting a small sample of the tumor, and this is obviously in the context of uveal melanoma or presumed uveal melanoma. So we're getting a small sample of the tumor, and most of the time this is for prognostication, basically for determining the risk of metastatic spread in the future. We also know that sometimes we can use this for diagnostic confirmation, basically meaning to confirm that this is a uveal melanoma by looking at the cells in pathology. But for the most part, it is a clinical diagnosis. And so we usually use the biopsy to determine risk of spread down the road.
Okay, so you talked about a fine needle biopsy. So before we, well, I guess let's talk about the mechanisms of like what does that mean? Because a lot of the patient community have been told by doctors or just throughout various different times, you know, we hear it floating around in the cancer community that like, oh, don't get a biopsy; it's going to make your cancer spread. Can you talk to us about like how does this biopsy physically work, and what are the risks, and what are kind of the safety features, I guess, that are kind of a part of the process?
Yeah, sure, absolutely. So when we think about a fine needle, we're really talking about a very, very small gauge needle, sometimes 25, 27, or even 30 gauge, depending on which provider is performing the biopsy. So depending on the location of the tumor, the biopsy approach can be different. So if the tumor is closer to the front part of the eye, then sometimes you will go through the wall of the eye directly into the tumor, and that gives a pretty good sample. If the tumor is closer to the back part of the eye, then it's hard to rotate the eye around to get the needle to go directly through the wall of the eye into the tumor. I know I get asked all the time from patients if we remove their eye during the biopsy and things like that. And thankfully, we don't do anything like that. We just kind of rotate the eye as needed. But if the tumor is in the back part of the eye, then we have a needle go kind of from the side and it goes through the vitreous cavity, through the gel in the middle, and then into the tumor from the inside. And so this is actually quite effective in terms of yielding results for prognostication or the understanding the risk of spread in the future, higher than 95% in most cases, but that does depend a little bit on the size of the tumor. So the thicker the tumor, the more likely you are to get positive results. Obviously, the pros of this is basically to stratify your risk. So basically to determine what chances you have of spread for the future, number one. Number two, to determine how often your body should be checked for metastasis as a result. And number three, to kind of give some guidance a little bit about how you should approach things. And I think patients can find that helpful from an emotional standpoint, depending on which stage or which class of tumor is diagnosed on the results of the biopsy. From the risks or potential complications of the biopsy, it is theoretically possible to have spread of the tumor, but that is so, so rare. When this technique is done appropriately, it's much, much less than 1%. And actually, if you look at all the reported literature, there are very few cases, and you're thinking, you know, these are thousands of biopsies that are done per year. And so the risk is exceedingly low. The most common risk that we see probably is bleeding into the eye from the biopsy. But even with this bleeding, the vast majority of the time, the blood goes away on its own. And so it doesn't require another treatment, procedure, or surgery to clear up the bleeding in most situations. There is also a low risk of retinal detachment, which can be surgically repaired. But again, that is not something that happens that often. Something, you know, depending on which study, somewhere between 1 and 4% can develop that. So, in general, I think it is a very safe technique, a safe approach, and it does provide really good information for the patients about the risk of spread for the future.
Yeah, and that was actually something I asked in a Facebook group today. I just asked, you know, what are some of the things that you wish as a patient you had known about the biopsy ahead of time, um, and you know maybe things that you were misinformed about, or things that were not told to you, or did you not have a biopsy for any reason? And just some of the people commented. Well, one of the person's people, I can't use the right verbs today. Nouns. See, it's a problem. The most important thing is that it's not just for idle curiosity. So, like, it really is very clinically sound data. And it's data that Dr. Harbour and the Coog-1 study is where this came from, the Castle test.
That is correct.
Yeah, so historically, like it has been around for over 10 years now. And obviously 10 years ago, the testing was maybe not quite as accurate, or it didn't exist in the same way. But having that information now takes you from your doctor has to, because, well, I guess what I have heard from patients that were diagnosed 15, 20 years ago is that you got this diagnosis and you were told, like, get your affairs in order, whether your tumor was 1 millimeter thick or 10 millimeters thick. Like, it didn't matter the thickness. Everybody just treated it with the most caution possible. And so that, in turn meant that everybody's patient had the most stressful situation as far as the emotions of this go as possible. Now, we do know just from the data that roughly 50% of the people diagnosed each year are going to be in that class 2 category. So before we kind of talk about those percentages, do you want to just walk us through the classes of, like, what are the classes, at least in the Castle Decision UX uveal melanoma, or Decision DX uveal melanoma test?
Yeah,
Um,
exactly. So I think the main two categories we have are class 1 versus class 2 tumors. And class 1 probably makes up about 2/3 of the tumors that we see. And, with the original Coog study that you mentioned, this had about 450, 460 patients in it, and it was evaluated prospectively. And so basically, what it showed was that class 1 tumors had a low likelihood of spread to other parts of the body, whereas class 2 had a much higher risk of spread to other parts of the body. We then looked with further follow up at the class 1 lesions, and we saw that there were some class 1 tumors that did end up spreading over time, obviously a much lower percentage than the class 2. And so we tried to kind of help determine which class 1 lesions would be more likely to spread. And so for a while, initially, they were divided into class 1A and class 1B, with class 1B presumably being more likely to spread than class 1A. And I think we are currently evaluating over 2,000 patients with the Coog-2, Coog standing for Collaborative Ocular Oncology Group. Over 2,000 patients, looking not only at the classes, not only at some of the tumor characteristics in terms of the largest basal diameter and thickness, but also looking at PRAME, another marker which we can discuss in a little bit, to kind of help differentiate which tumors are most aggressive and how we can get the most accurate information for our patients about what these test results mean. I apologize, Danae. I don't quite hear you.
I muted myself. It's fine. So we've got the class 1 patients that you said make up roughly 2/3 of patients diagnosed. So I guess if we put 3,000 people are diagnosed in the States per year, then that's roughly 2,000 of the people are in that class 1 category. So we've talked a little bit about kind of, I think we've alluded a little bit to kind of the split between those, but we've got patients who are going to come in with a class A, 1A, or a class 1B. So can we kind of talk about the difference between those two? And maybe, I guess this would be maybe a good time to go into those, like, percentages and what do those percentages mean, so that patients, because I know, like, when I got my diagnosis of class 2, like, initially it was terrifying. It was like, oh my word, this is so bad,
Mhm.
which arguably could be said, but let's just kind of break the numbers down so that they're understood.
Yeah, sure. So I think, when you're looking at class 1A lesions over about 5 years, it's about a 2% risk of metastasis, or about a 2% risk of spread to other parts of the body. And so obviously that's a fairly low risk. As far as class 1B goes, that tends to be about a 20% risk of spread to other parts of the body. And then when you look at class 2, that's a bit more aggressive, so over 50% and up to about 70% risk of spread to other parts of the body. But there are a couple of caveats with this that have been published on in a number of different articles. And I think one is looking at the largest basal diameter. So basically, if you have a very, very small class 2 tumor, even though the numbers say overall there might be a 70% risk of spread, the actual risk is likely much lower. And so if you have a class 1A or class 1B lesion that does have a very, very largest basal diameter, then it is possible that the risk of spread might be a little bit higher than what it shows in the overall data. So the cutoff usually is somewhere around 12 millimeters, but that is one important caveat. And then the second caveat, which we briefly mentioned and we'll probably talk about more, is PRAME. And that kind of plays a role in the percentages and the risk of metastasis as well.
Okay. Was there another? I know the basal diameter. Well, let's just break down what are the pieces of our tumors. We've got the basal diameter, which I'm pretty sure that means the bottom diameter, right? So like
Yes,
if
the
we're
base,
looking at like a bubble that's on the surface of a table, maybe the basal diameter is what's touching the surface of the table,
that
correct?
is correct. That is
Okay.
correct.
So then the thickness is how far up does the bubble go?
That is
Or,
correct.
I say bubble. It's usually not a bubble shape exactly for everyone, but for
Sure.
for the terms of this. So that thickness, does that thickness play a role in any of the studies that we've seen? As
Yeah,
far
that's a
as
thing.
say like a class 2 tumor that's a really thin tumor versus a class 1 tumor that's a really thick tumor.
Yeah, that's a fantastic question. In a lot of the studies, it does not necessarily seem like thickness, independent of other characteristics, plays a role, although there are a couple of retrospective studies that show that the thicker the tumor, the more likely there is for metastasis. But I think, with the COOG2 results coming out soon, we will kind of get a little bit more information about that. But it seems like largest basal diameter plays the most significant independent role, as
Gotcha.
in addition to the classes, the largest basal diameter also gives you additional information, whereas thickness tends not to give you additional information on its own, separate from the classes or largest basal
Okay.
diameter.
So when all the factors are combined, that basal diameter is um, or sorry, when all the factors are combined, the thickness is a role. It plays a role, but when the factors are kind of separated into categories, then that basal diameter can, in and of itself, indicate yes or no to the spread. Okay,
Correct.
gotcha. Okay, let's talk a little more about PRAME. I know we've kind of talked briefly about it, but what is the difference when somebody sees on their Castle test that it says PRAME positive or PRAME negative, regardless of class A or B, as in the one or class 1 or 2? What does that mean, and
Yeah.
why does that exist?
Yeah. So PRAME is an antigen that it stands for preferentially expressed in melanoma. And so this is something that is only found in normal tissues in the testes and a couple of other locations. And when it is seen in tumors, we know that those tumors have a more aggressive profile and are more likely to spread. And so looking at some of the older data that we have with patients with melanoma, we know that if you have a class 2 tumor that is PRAME positive, you are more likely to have spread or metastasis, and it also tends to happen earlier. When we look at class 1 patients that are PRAME positive, it seems like most class 1 patients that are PRAME negative really don't have much spread. And that's almost regardless of class 1A or class 1B. But once you have class 1 tumor that is PRAME positive, you are more likely to have metastasis. And if we compare the class 1 PRAME positive versus the class 2 PRAME positive, there is a little bit of a difference in those patients. The class 1s tend to be a little bit younger. They have a less likelihood of tumors going to the liver, and the spread seems to be delayed compared to the class 2 patients. So PRAME gives us a lot of information and really helps us understand in more detail, if you have class 1, A, B, or class 2 tumors, what the risk of spread is.
Okay. So, one of the pushbacks that we get to the biopsy from various different doctors or even from patients themselves, and often from insurance, unfortunately, is that having the physical biopsy of the eye tumor done does not it does not typically yield any kind of care for your eye, right? Because we're looking at prognostic testing, we're looking at the possibility of metastatic spread. And by definition, metastatic means outside of the primary tumor location, which means not in the eye. So, as an eye doctor, why is this important information for you to have to give to your patient?
Yeah, I think, the most important reason for us is that even though we're eye doctors, we are thinking about this as oncologists, and our goal is to take the best care of the patient overall, not just their eye. So I agree completely that this information is not really going to change how we approach treating the eye, because that decision is already made, whether it be radiation or enucleation, or any other treatment. But the reality is that this is the prime opportunity that we have to get the information about the tumor, so we can kind of track things for the future. So we know how often the patient should get scans of the rest of their body. So we know what the risk is of spread to other parts of the body. And for future indications, with adjuvant therapy, so the possibility of reducing the risk of metastasis before it develops, and also potentially down the road, as we get more information, we may open different clinical trials for specific treatment options, and we would really want to focus on the patients that have the highest risk of spread in that scenario. And so, the caveat to this is, we cannot get accurate readings for this biopsy once a patient has been radiated. And so once radiation treatment is done, the window for getting the biopsy information has passed. And so that's why it's so important to get it up front. And that's why us as ophthalmologists, we're the ones that do the biopsy, but we also are the ones that are participating in the care at the time where we can do the biopsy, because this will yield results for many years to come. I do know, you had kind of mentioned that some people say, well, what's the value of doing this biopsy? Because perhaps there's not a lot of adjuvant trials right now. Perhaps we can't offer patients something to reduce the risk of metastasis right now. That may be true at this exact moment. There's not currently a clinical trial open to reduce the risk. However, down the road, if we get more information, we would really we would want to know which patients would qualify for these studies. And by
Mhm.
not having a biopsy, you may miss the window or the opportunity for stuff that is being developed and will come to market and will be available in clinical trials down the road.
Oh, I love what you said about how you're approaching this um, as the doctor of the whole patient, right? Like, yes, you are primarily an eye doctor, but your patient is a whole person. And so your job as the doctor is to make sure that the patient has the best care, the best follow up care. And you're thinking about this not only from a whole patient perspective, but also from an oncology perspective. And from an oncologist perspective, cancer can spread. And so we need to know, how often do we need to watch, right? How often do we need to watch for this to come back? And at what point, is the patient kind of considered a little more safe, or not, not as high of risk? Um, so speaking as, an ophthalmologist, an ocular oncologist, someone who does this test, treats the eye, what does this look like for you, or what would be maybe the ideal situation, right, for a patient who, say, is class 2, they get that biopsy result, and you're looking to make sure that they have informed follow-up care, and are you primarily the doctor who covers those scans and makes sure that those happen, or do you send those patients when possible to a medical oncologist? And like,
Yeah,
what
so
informs that decision?
exactly. So that's another fantastic question. And I think anyone who in my clinic has a high risk of metastasis, whether it be a class 2 PRAME positive or negative, or a class 1 PRAME positive lesion, especially if it has large basal dimensions, I work very closely with our medical oncologists at the University of Miami and the Sylvester Cancer Center, and we basically refer them right away. Because what I want to happen is, I want a medical oncologist to talk to the patient from the beginning, to let them know the importance of the scans, why we're getting the scans, to also talk to them potentially about treatment options. And, this is an exciting time to be an ocular oncologist that treats patients with uveal melanoma, because we know that tebentafusp is a new medication, or Kimtrack, that was recently FDA approved. It's the first FDA approved medication to treat metastatic uveal melanoma. And so, patients that would benefit from this treatment have a specific HLA type, so a specific marker in the blood. And so that's another reason I like to get patients in to see our medical oncologist, because we will often analyze for that marker early on. So if the patient were to develop metastasis, we already have this information, and we would be able to kind of initiate treatment right away, as opposed to kind of waiting for that test. So I think that's how we tend to approach patients who have a high risk of spread, by getting them into the medical oncologist right away, so their imaging can be done and deeper conversations can be had. I also know that as the ophthalmologist, I get patients all the time that ask, well, what do I do with this information? And if I find out that I have a high risk tumor, how scared am I going to be? How much is this going to affect my life? How much is anxiety going to kind of affect me? And maybe it would be better for me not to know. And it's actually interesting. Obviously, every person is an individual and is different, but we did look at this with the team from Castle Biosciences and some of the people from the Melanoma Research Foundation. And it actually shows that the vast majority of people are happy that they got their tests done. If they had a low risk of spread, they felt that it gave them some relief from anxiety, and a high risk of spread. They also felt that it was a valuable test because it helped them understand and feel like they were playing more of a role in their treatment. They were able to participate in the interactions with the oncologist. They were able to kind of think about their life and perspective. And patients actually ended up doing very, very well emotionally with this information overall. However, if patients are struggling in this kind of scenario, we also utilize the resources at our cancer center, where we will have a psychologist, psychiatrist, nutrition, acupuncture, water therapy, and various other options for patients who are struggling with the diagnosis, and with the class results and with the prognostication information. So I think that's really valuable too, as you were mentioning, kind of taking care of the whole patient. It's not just treating the lesion in the eye. It's not just monitoring the tumor. It's also trying to think about the anxiety that comes from this, and the challenges that go with that as well.
Well, I think that's so valuable. And I feel like we might have talked a little bit about the mental health aspect of this in previous discussions, but it is very much worth revisiting. And I'm not sure how much of an awareness you have of like kind of some of the patient things going on in our community, but we've definitely had a few heavy hit losses the last few months, especially just like on the Facebook community, and just the online community has felt those losses really, really heavily, of Clay and of Dustin and various other people, like just kind of, rapid fire dominoes. And it feels very, well, yeah, like it's a very triggering, anxiety ridden kind of a thing to watch people that you know or people that you've interacted with online who were doing well, or seemed like they were, and then suddenly they're not. So I think that, like you said, I think it's so important to pay attention to those kinds of things, and as a patient too, or as a caregiver, pay attention to your person that you're taking care of, and watch for those signs that they're struggling emotionally, so that you can talk to their doctor and ask for those resources. Because I think that it's amazing. And I wish that every office would do this, where they would look for that and they would plan for that. And I think, honestly, I feel like it probably should just be a general assumption in cancer that if you have a cancer diagnosis, you're probably going to struggle emotionally and mentally on some capacity. And you need to have that available support made known to you. So I love that you guys make that accessible and you make that a priority. Um, this is kind of switching gears a little bit, but let's just say the patient is having a biopsy done, and there's some information. I think I've seen this, maybe it was a presentation from Dr. Harbour himself, or people see different things online and they hear different things about how the biopsy is taken. We know it's the fine needle biopsy, but there's say, I don't know, a basal diameter of 15 and a thickness of 12. Like, there's a pretty big surface area, and we've got one tiny prick of this needle. So how do you know that it's going to be accurate? I think you mentioned like a 95% accuracy. But what happens if it's wrong? And what's kind of like, what does that margin of error look like, or can it look like in that biopsy?
Yeah, so I think that's a fantastic question as well. And I think this is something that if you talk to different people, you may end up hearing different things. So basically, we do know that when you have large tumors, there are some parts of the tumor that can look old and not very aggressive, and there are other parts of the tumor that may look more aggressive. And so there's a question as to whether or not there's a different kind of DNA or RNA or mutational burden in different parts of the tumor. And how do you know whether or not your single biopsy is representative of the whole tumor? Or let's say you even did two biopsies in two locations and you got different information. How do you know what's most accurate? So there was a study that was done by Dr. Jim Augsburger, who biopsied tumors multiple times and sent them off. And it showed that 9 out of 80 patients had a different result between the two biopsies. And so I think And then we've also seen on some pathology studies that there have been different types of cells in the melanoma, some less aggressive and some more aggressive in areas. And so that leads us to wonder whether or not we're getting the accurate information. And so I think there's a couple of ways that we approach this. When we're doing the biopsy, we try to target the most aggressive looking portion of the tumor. So if there is a small chance of heterogeneity or differences in the tumor, we try to get the area that's most aggressive or most likely to have kind of the aggressive information. Then, on top of that, there are additional tests that are also being run by Castle these days, in addition to the class stratification and PRAME testing. There is next generation sequencing looking for mutations. And so this basically helps us, number one, confirm that it is a melanoma. But number two, if we see a mutation of BAP1, we know that tends to be a more aggressive mutation. And so that gives us additional information to kind of help us sort through if there are differences in the biopsy results. In general, we think that as a tumor becomes more aggressive, those cells kind of take over more and more of the tumor. And so, most of the time, somewhere around 90% of the time, you are getting the accurate information of the tumor, perhaps more than that. And I think this is kind of the best information that we have right now. And so, as we learn a little bit more with the COOG2 information and others, we can kind of update on that. But it seems like the biopsy, the vast majority of the time, is very, very accurate in giving us the prognostic information.
Okay. I feel like that helps. And that I feel like that helps explain too, like some of those different studies I think that Dr. Harbour has presented on in some online forums and things where he's talked about the various different kind of makeup of the tumor and how it's not just this homogenous thing. Like it has different elements and different DNA makeups. But I think it was Dr. Scott Walter, I'm sure you know him, but he said something along the lines of that next generation sequencing is like a spell check. It's like, okay, if we have a class 2A or a class 2 PRAME positive, and then we also see BAP1, GNAQ11, like some of these other very classic mutations, then that's kind of our confirmation that we got the right information, or that, that we have the best information to work with, basically. Um, Obviously, the preferenced or the preferential kind of circumstance here is that even if you have all those mutations, that you still end up not metastasizing. That'd be great, right? Like we all want that for every single one of the patients that gets a class 2 diagnosis. But for the ones that it does spread, what's the value, as as an oncologist, from an oncologist perspective, what's the value of finding that metastasis early as a result of those scans happening every 3 months or every 6 months due to scan protocols? What's the benefit to you as the doctor treating the patient?
Yeah. So I think that's also another really valuable point. I think obviously we already mentioned that tebentafusp or Kimtrac is currently available for treatment. So obviously that's one characteristic. But also, depending on where disease has spread, there are a number of other treatment options that could be available. If you have a small single metastasis, sometimes surgery is an option to remove that lesion, and sometimes that can actually be curative. Sometimes there are liver directed therapies that can be done. And so the earlier you catch disease, the smaller the tumor is. There may be some benefit in some patients for that. And I think we will learn even more about this over time as we kind of get more information with tebentafusp and potentially other medications that seem to be doing pretty well in clinical trials right now also.
Yeah, of course, for sure. You mentioned the BAP1. So this was kind of a confusing point for me because I have now, like, as most of I think you know this and most of the community know, like I had metastatic spread to my liver that was treated surgically, and obviously the biopsy was performed on whatever small pieces they could use. But my eye, when I looked back at my Castle test for my eye, I didn't have that next generation sequencing. I don't think it was available at the time that I was diagnosed. I think it came out like 6 months after. And regardless, it didn't happen, even if it was available. And so some patients have, class 1A or 2, let's just say class 2. Let's just use class 2 because that's a pretty like blanket. You're going to have some mutations.
Sure.
So class 2, PRAME positive, BAP1 mutation. There's some people in the community who have kind of a predisposition due to the BAP1 to other cancers. So, what's the difference between the BAP1 and the eye? And the BAP1 test that is part of a blood test that your oncologist, your medical oncologist will do or can do to kind of evaluate your risk of other cancers.
Yeah, for sure. So I want to address the first comment you made about the next generation sequencing and availability. You are correct that this is a more recent test in terms of being offered with the rest of the Decision DXUM biopsy information. However, for some patients, especially if they've been biopsied over the last few years, there may be some residual sample that's available where those next generation sequencing analyses can be run to look at the mutational burden. And so that's something that may be worth discussing with your treating physician, because that's something that could potentially be helpful. Separate from that, um, in terms of, sorry, can you remind me the second part of the question?
So there are patients who have BAP1 mutations in their tumor,
Ah, yes.
but who don't have a BAP1 mutation in their blood.
Yeah.
So, a blood test from the medical oncologist. So I don't have the BAP1 mutation in my blood, but it is in my tumor. So that's I guess to help kind of let's help make sure that I say it correctly and then you correct me. I understand it as the blood test is something that evaluates familial spread possibility and also your risk for other cancers. But the eye test that looks at, okay, the eye or even the liver cancer, like if you have a liver tumor or a lung cancer that shows up, a lung metastasis, that BAP1 is kind of that's the way to confirm it's uveal melanoma. Um,
So so yeah, I think that's a great point and a really good distinction. So if you have a BAP1 mutation in the tumor itself, that indicates that you're more likely to have spread to other parts of the body. I agree with you on that. If you but the tumor is localized, the BAP1 mutation is localized just to the tumor. If you have a BAP1 mutation elsewhere in your body, that is a familial form of the mutation, and that is seen in about 5% of people who have uveal melanoma. Usually it's people that have a family history of various types of cancer. So skin melanoma, uveal melanoma, renal cell carcinoma, and different types of lung cancer as well, especially mesothelioma. And so, if there's a person that has a family history of, I not only ask if people have had melanoma or these cancers, but I also ask if anyone in the family has had an eye removed, because sometimes people don't know that history, but having an eye removed can be an indication of a melanoma in the family. If a patient is very young, so we know that most people that are diagnosed with this are in their 50s, 60s, or 70s, but there are people that are younger that can have this condition. And so, if people are younger, then I would also consider testing for BAP1 because it tends to be something, because the person doesn't fit what we normally see. And so you test for BAT1 not only to think about their risk of passing it on to their children and kind of giving counseling to the family members, but also to make sure that we're surveilling the rest of the body for those other types of cancers which can pop up as well. So you did an excellent job describing the difference.
Okay. No, I feel like that was just a good distinction, and that was something that has come up as far as prognostic testing. Like, well, what does this information mean? So, thank you for explaining that. I think just to close, I have two other points that I wanted to make, or that I want us to kind of cover. And one of them is just, can we reiterate what, as far as you understand right now, what is the cost to the patients for this test? Specifically, we know for the Castle test. So let's just talk in terms of the Castle test, because a lot of times that can be a factor for patients, that they're uninsured or they don't have good insurance, or even their insurance comes back and says, no, we won't cover this test. What has been your experience for patients who that happens to?
Yeah. So the first thing that happens is Castle will always charge the insurance for this test. And if the insurance does not authorize approval, then the physician works with Castle to write a letter of appeal, and then Castle will automatically appeal the ruling. And that kind of goes back and forth. And I know this is really important because during this time, patients are getting information about the bill, which can be somewhat expensive. And without knowing that this is going on in the background, patients can be concerned, sometimes freak out about the expense and the cost. In my experience, though, if the insurance company denies approval and also denies the attempt to overturn the denial, then Castle usually just covers the cost themselves, and the cost does not get transmitted to the patients. And so I think that is something that has been really fantastic on the part of Castle, to allow patients access to this really, really important information, so that they're not stuck paying thousands of dollars for this kind of test if their insurance company doesn't approve it. And I think on the physician side, from an advocacy standpoint, we are working pretty hard to try and express the importance of this, so insurance companies will get on board and authorize and approve this. But even if they don't, Castle has been working to make sure the patients are not stuck with this bill.
No, I think that's so important. That can be so relieving to hear, because I mean, I remember having that experience of seeing it come in the mail and not knowing what was happening behind the scenes, and I was so alarmed. I was like, "Oh my gosh, what is this?" So, thank you for explaining that. I feel like hopefully that will alleviate concerns for anyone. So, the we had a couple questions come in that I want to get to in just a couple minutes, but I guess one of the last things I want to ask you is, what would you suggest to a patient who their doctor, their treating physician, maybe a retina surgeon, or maybe they're just not as familiar, but they know what to do to treat ocular melanoma? What happens, or what should happen for the patient who they're told you shouldn't get a biopsy? What are maybe the reasons that, as a doctor, you would say this is a good reason, or that you would say, get a second opinion?
Yeah. So the vast majority of patients that I see, I would recommend a biopsy. If there is a very, very small lesion, so if the lesion is less than 2 millimeters, let's say, especially if it's in a sensitive area for vision. So if it's in the macula and it's very, very small, a physician might say, we can do a biopsy, but number one, the yield is going to be lower. So the chances of us getting enough helpful information from that biopsy may be lower. And by doing the needle biopsy, because it's near the center part of your vision, it may affect your vision. I think that is something that is a reasonable consideration for avoiding a biopsy. There are some people still that'll say, well, this biopsy result is not going to change what we do for your eye, and potentially won't change what we do for the rest of your body, because we can look at the size of it or the thickness and say we should get you scanned this often. I think as we now have availability for treatments for metastatic uveal melanoma, and with the science changing so rapidly, I think that it is definitely worthwhile to have the biopsy, so we can have this information for the future. So honestly, outside of really challenging technical situations of the lesion being quite small or being in a quite sensitive area for the vision, I think a biopsy is really warranted in most scenarios, as long as the patient is on board with it.
Okay, I feel like that's a good way to explain it. Um, And I think just knowing so many of you guys, as far as the ocular oncologist field, I know you guys are all very tightly knit. You communicate very well together. You collaborate a ton, obviously, with the Coog studies and various other different conferences. Like, you guys know each other. And so if someone is treating ocular melanoma and they know what they're doing, like, and they're suggesting not to have the biopsy, it's I guess what I'm hearing is it's likely with good reason. Um, because you guys have enough interaction with each other to educate each other and make sure that everyone is kind of up to par.
One point that I would make is, it depends on where you're getting treated. There are going to be people with different opinions. The
Mm,
vast majority of us think that biopsy is appropriate. If for whatever reason you're in a scenario where somebody recommends that you don't get a biopsy and you're concerned about that, there is a large network of ocular oncologists, and feel free to reach out through you, Danae, or contact kind of any of us that are ocular oncologists, and we would be happy to either kind of chat with you briefly about things, or potentially even see you for a second opinion, just so that way you can feel comfortable. Obviously, this is something that you want to move on pretty quickly, and so you don't
mhm.
want to delay your treatment. But at the same time, we know that if you don't take advantage of the biopsy at the time of treatment, that window kind of passes. So I do think that's an important decision making time.
Okay. And I didn't think about this until now, but you mentioned the having the eye removed. I do know that Castle does test the nucleated eyes. And obviously, if it's enucleated, there is no question of can we biopsy it or can we not, because it's no longer a threat to the patient or the body or the vision. Um, but do you happen to know, is it only Castle that biopsy samples can be sent to, or are there other centers that do like a full scale, like slice pieces of the eye to look at everything under a microscope. Because
Yeah.
I know I was a little confused. My eye went to UCLA first before it went to Castle, and I was like, "What?"
Yeah. So the pathologist, in order to analyze the tumor, it requires a pathologist, usually that's trained in ocular pathology. And so there are very few of these across the US. We're obviously fortunate in Miami to have one, but sometimes people, in order to have the melanoma assessed, will send it to a center that has a pathologist that's comfortable reviewing ocular tumor samples. Um, as you mentioned, Castle will take tissue from after enucleations. And so you can have specimens on slides and they can evaluate that as well. There are other companies that do evaluation for prognostication. I know Impact Genetics looks at DNA mutations, so looking at chromosome 1, 3, 6, and 8, with 3 being the most important one. And they can look at and evaluate samples post enucleation as well.
Okay, that's good information for sure. Because I know some people do end up with enucleation for one reason or another. Okay, so on to our final questions, and then we will wrap up. So, one of the questions is, do we have a test yet? Or do you hope as an ocular oncologist that there will be one soon to be able to like tell, are we predisposed, or maybe, for our generations below us, for those of us diagnosed younger, are there tests in the works or hopeful for diagnosing the predisposition to ocular melanoma to begin with?
So yes, there is for the familial type of melanoma. There's definitely a blood test, and you can also get a saliva test. There's a number of companies that do that, and they can actually mail the kit to you. You can mail it back and get the results. And so, we do offer that to many of our patients. If it's outside of the familial scenario, in terms of a patient that has, no family history and no eye issues, we don't have something available right now, and I think it'll be a little challenging for us to determine who's most likely to get uveal melanoma without any of those other
Mhm.
predisposing factors.
So, if you're the first generation diagnosed person in your family, would that then merit your immediate children, or grandchildren, if you have grandchildren, like then having any kind of a familial test done? Or do you think that that's not necessary
So,
unless there's a multiple time of it happening in a family?
yeah, I think if you're a more typical patient with uveal melanoma, if you're in your mid 60s, if you have light colored hair, light colored eyes, have freckles, you're more likely to be someone that develops uveal melanoma. And if you have no family history, then I think it's reasonable to not pursue testing. However, if you're younger or less likely to have melanoma for other reasons, or you're just really concerned and you want to make sure that this is not a risk for family members, I think the best thing to do initially is to have yourself tested first. And if you're negative, then you don't need to pursue anything for any of your
Mm.
additional family members. And if it does come back positive, then it'll be worth a conversation with other family.
So the tests that can be done that, for, I guess, basically saying, obviously it doesn't help us other than to know, do we need to have our family tested? But if I were to do that test, do you have a list of a couple of those names of companies that you would list off that people could bring to their doctor if they wanted to have that test done?
Yeah, so I think My Retina Tracker does it, Invitae does it, and I think there are a number of other ones that are smaller companies that do it as well. Those two I know well because they do a lot of genetic testing for other retinal conditions,
Okay.
and so those are the ones that I use most frequently. But there are a number
Okay.
of other tests.
All right. Well, I just feel like that's a good starting place for if people do want to have that. And is that a test that an ocular oncologist orders, or is that one that a medical oncologist can order?
Both can order it. In fact,
Okay.
I have my team send the kits out to patients' houses if they want this testing done, or if they have, if they're quite a young patient, et cetera. So I do order it for some of my patients as well.
Okay. And then the last question is, do we have any kind of a test, or, various tests that are successful in diagnosing the circulating tumors, like tumor cells? I think it's the circulating tumor DNA or circulating tumor cells. Are there blood tests that are conclusive or, consistent, I guess is the better word, in diagnosing that?
Yeah, so this is a question basically about liquid biopsy. So determining if we're able to assess cells from the tumor that have broken off the tumor, and they could be circulating either in the eye, in the anterior chamber, or in the blood. And so I think this is actually the early days of liquid biopsy for uveal melanoma. And I know a couple of centers are investigating this and have shown that you can get some circulating tumor DNA in the blood, especially immediately after radiation. There's been some information in the vitreous, and I think, there are places that are looking in the anterior chamber as well. As of right now, based on uveal melanoma itself, the fact that it's in the choroid, less likely to go to the vitreous and other areas, I think, we still don't have enough information to say definitively that this testing should be done. But I think over the next few years, we are going to really learn a lot more about this. So this is one of those areas that we're developing a lot of information on. So kind of stay tuned.
Okay, well, I think that's a good place for us to end for the day. Is generally, we've got a lot to work with. The biopsy is important and it's important information and valuable to you. So if you can get it, great. If you didn't get it, move forward and use the information you can get moving forward. Um, and just stay tuned for the results of the COOG-2 study, as well as our ION research and anything else that comes in the next few years. So thank you again for being here with us, Dr. Williams.
No, always a pleasure being with you. Thanks so much for having me again. I appreciate it.
All right. Well,